switching gear a bit to SDHB, I'll say it's similar to HLRCC, but I will say that it's not as aggressive. So we aim to resect them when they're still small, but they don't have to be tiny. I generally aim for about 1.2 to 1.5 centimeters, large enough that they're still small, but big enough that they can be found easily with intraoperative ultrasound. And you know you're not going to violate the tumor by accidentally going into it. You can really characteristically see it. So I actually do these surgery, and most of us will do this one for SDHB minimally invasively, but take care to have wide margins and not violate the tumor.
Yeah, and I think for that there is some patients that have adrenal masses either concurrently or separately, right? So that's something to keep in mind for those things. But I think I remember the key point. I think you brought it up, right? Is the genetic basis of these tumors tends to be on kind of the Krebs cycle, glycolysis, or kind of that pathway, which I can't speak very intelligently about right now. But in return, I remember that I think this is the one area that a PET scan, right, that may have some use. Is that still the kind of general basis for this?
Absolutely. And I can talk a little bit about the biochemical standpoint from this. And it may help be informed here, both from the trial standpoint and from this. So from a biochemical standpoint, I promise I'll make this brief and clinically relevant. These tumors are canonical examples of what's called a Warburg effect. So essentially, these cells undergo what's called aerobic glycolysis. As a reminder, remember, that's when these cells still preferentially use glycolysis for their energy needs, even though there's a lot of oxygen available. And this is because of the alterations in that FH gene. So we actually see these effects in tissue culture when these HLRCC cells and SHB cells require high levels of ambient glucose to be present to survive. And so this really translates over clinically because this means that these are very PET avid on FDG PET. And although it's challenging to discern if a renal mass is present because there's a lot of background activity with the standard renal parenchyma, FDG PETs can be very useful to assess for metastatic disease, and they're our go-to as well for functional imaging.
That's great. And it actually is a great segue into what I really want to talk about next is, we talked about surgical management HLRCC, but as we know, HLRCC is super aggressive. It requires at times, the majority of those patients probably progress on some type of metastatic disease if left untreated, right? And I think at time of diagnosis, they can have metastatic disease for sure. And so systemic therapy is, I'm sure, a huge aspect of their treatment as well, being surgery or no surgery, right? So in that scenario, talk to us a little bit about the recent paper you guys published. And I think you guys just did this with Dr. Srinivasan, I think was one of the authors, and you were on there as well. It was published in New England Journal of Medicine. It actually, the use of 2 different drugs for treatment of metastatic disease compared for both sporadic patients as well as germline patients. But help me understand a little bit more about this paper.
Sure. This was a labor of love led by Dr. Ram Srinivasan, one of my mentors and principal investigator on this study. So this was an investigator-initiated phase 2 single-center open-label trial conducted here at the NIH Clinical Center. So it assessed the combination of bevacizumab, which targets VEGF, and erlotinib, an EGFR inhibitor, in 2 cohorts of patients, those with advanced or metastatic sporadic papillary tumors and those with advanced or metastatic HLRCC-associated tumors. So for a little background, as you mentioned, metastatic HLRCC has been very challenging entity to treat. Very small retrospective studies showed only modest outcomes with types of monotherapy and combination TKIs. So about 15 to 40% overall response rate, depending on the study. But more importantly, the median overall survival was poor, and it ranged only from 16 to 21 months, which really kind of highlights the aggressive nature of this disease. Yeah. So as I mentioned, our principal investigator really espouses that bench to bedside approach. And so we talked a little bit about the energetics of this tumor, how with FH, how it alters what's the Krebs cycle and the cellular energetics. And that's why you see a lot of FDG PET avidity. So we hypothesized that since these cells are so reliant on this aerobic glycolysis, if we could disturb this glucose metabolism, if we could take advantage of this metabolism, can we use these drugs or use certain drugs in combination to specifically target this? Mm-hmm. So we know EGFR signaling is important for aerobic glycolysis, and therefore erlotinib, an EGFR inhibitor, was chosen. Mm-hmm. We also know that if you lose this fumarate hydrase activity, you have this big accumulation of this substrate of fumarate. And long story short, fumarate is an oncometabolite. It does this process called succination, in which it can change some post-transcriptional modification. And in the setting of RCC, this succination eventually helps stabilize HIF, which leads to a similar process of what's called VEGF upregulation that we notice in standard sporadic clear cell RCC. So therefore, we used bevacizumab, a VEGF inhibitor, as a second agent.
Got it.
Going back to the study, patients on the study had to have advanced or metastatic papillary RCC or HLRCC-associated RCC. They could receive no more than 2 prior regimens targeting the VEGF pathway, and they could not have received prior bevacizumab. About 95% of the patients in the HLRCC cohort had germline testing, which determined the pathological epipathologic FH alteration.
Sure.
So we enrolled 43 HLRCC patients, 40 sporadic papillary patients. Most were IMDC intermediate risk, and about half the sporadic cohort had received prior therapy, and only 20% of the HLRCC cohort had prior treatment. And for the HLRCC cohort, the outcomes were actually quite favorable. Our overall response rate was 72%, and 5% of those patients experienced a complete response. Responses were similar along all IMDC risk groups, and patients were quick to experience their responses with a median time of less than 2 months. All the patients who did not experience objective response, they ended up having stable disease, 3/4 of whom had stable disease for over 6 months. And the progression-free survival, median progression-free survival was 21.1 months, and the overall survival was about 45 months. In the sporadic cohort, the overall response was lower at 35%, and there were no CRs noted. Similarly, responses were quick, within less than 2 months, and median progression-free survival was about 9 months, and median overall survival was about 18 months. The toxicity, these are older agents that have been used for a long time, is very consistent with the prior studies. And I think the biggest takeaways from the study are that the combination therapy of bevacizumab and erlotinib is highly effective in patients with metastatic HLRCC-associated RCC, and increased the overall survival from that historic 16 to 21 months to 45 months. And it provided a durable response in them. And this combination also has activity in sporadic papillary RCC as well, and can be an option to be utilized here.